Nursing Care of Substance Use and Addictive Disorders. Module 3, Opioid Use Disorder and the Overdose Crisis. Opioid use disorder is one of the most urgent public health crises in the United States. As nurses, you will encounter opioid intoxication, withdrawal, overdose, and patients receiving medication treatment for recovery in emergency departments, medical surgical units, psychiatric settings, and community health clinics. This module focuses on what you must recognize immediately, what you must treat first, and how to respond safely and confidently. This is not about judgment. This is about airway, breathing, circulation, and long-term stabilization. Opioids are central nervous system depressants. They slow everything down. When someone is intoxicated with opioids, the most important system affected is the respiratory system. Classic signs of opioid intoxication include slowed respirations, decreased level of consciousness, and pinpoint pupils. You may also see hypotension, bradycardia, slurred speech, and cyanosis in severe cases. The most dangerous complication is respiratory depression. If respirations drop below 8 to 10 breaths per minute, this is a medical emergency. For NCLEX and real life, remember this. If you see unresponsiveness and slow breathing, think opioid overdose until proven otherwise. Withdrawal from opioids looks very different. It is uncomfortable, distressing, and dramatic, but it is usually not life-threatening in otherwise healthy adults. Instead of slowing down, the body speeds up. You may see anxiety, restlessness, yawning, sweating, dilated pupils, goosebumps, nausea, vomiting, diarrhea, abdominal cramping, muscle aches, and tachycardia. Students often confuse withdrawal with intoxication, so remember this clearly. Intoxication slows the body down. Withdrawal speeds the body up. Withdrawal feels terrible, but unlike alcohol or benzodiazepine withdrawal, it does not typically cause seizures or delirium tremens. Naloxone is a life-saving medication. It is an opioid antagonist, meaning it knocks opioids off receptors in the brain. It can be given intranasally, intramuscularly, or intravenously. It works quickly, often within minutes. However, there are two critical teaching points. First, naloxone may cause acute withdrawal. A patient who was unresponsive may suddenly wake up agitated, nauseated, vomiting, or combative. That is not a bad reaction. That is withdrawal. Second, naloxone has a shorter half-life than many opioids. This means respiratory depression can return after naloxone wears off. Continuous monitoring is essential. When administering naloxone, airway management and oxygen support always come first. Medication does not replace ventilation. Medication for opioid use disorder is evidence-based treatment that reduces cravings, prevents withdrawal, and lowers the risk of overdose. Methadone is a long-acting, full opioid agonist that stabilizes patients by activating opioid receptors in a controlled way. It is dispensed through regulated treatment programs and is typically given once daily due to its long half-life. Nurses must monitor for respiratory depression and QT interval prolongation. When used appropriately, methadone reduces mortality and is safe during pregnancy. Buprenorphine is a partial opioid agonist with a ceiling effect, which lowers overdose risk. However, if started too soon after recent opioid use, it can trigger precipitated withdrawal. Patients must be in moderate withdrawal before initiation. As nurses, we monitor sedation, respiratory status, adherence, and engagement in care. These medications are not replacing one drug with another. They are stabilizing brain chemistry and supporting recovery. Methadone is a full opioid agonist. It prevents withdrawal and reduces cravings. It must be dispensed through federally regulated opioid treatment programs, OTPs. It has a long half-life. It can cause respiratory depression. It can prolong the QT interval. It reduces mortality in opioid use disorder. It is safe in pregnancy. It does not create a new addiction. It treats opioid use disorder. Harm reduction saves lives. It includes access to naloxone, clean needle programs, safe injection education, and non-judgmental care. We meet patients where they are. Polysubstance use is extremely common. Many overdoses involve opioids plus benzodiazepines, alcohol, or stimulants. Combining opioids with other depressants dramatically increases respiratory depression risk. If you see altered mental status, do not assume it is only one substance. Think broadly, assess thoroughly. NCLEX prioritization. If a question presents a patient with suspected overdose, your first priority is airway, breathing, and circulation. If a patient is withdrawing and uncomfortable, your priority is symptom management and monitoring. If a patient is stable but asking about treatment options, your priority is education and referral. Always determine last use. Always assess respiratory status. Always screen for suicide risk, especially during intoxication and withdrawal. Safety first, stabilization next, long-term planning after that. Here are the clinical pearls I want you to remember. Pinpoint pupils and slow breathing should immediately trigger concern for opioid overdose. Naloxone may cause agitation. That is expected. Continue monitoring. Opioid withdrawal is miserable, but usually not fatal. Alcohol withdrawal can be fatal. Know the difference. Never delay life-saving treatment while completing a full psychosocial assessment. Patients receiving methadone or buprenorphine still deserve pain management. Do not undertreat pain because of stigma. Language matters. Use person-first language. Say person with opioid use disorder, not addict. And most importantly, recovery is possible. Your tone, your presence, and your professionalism influence whether patients return for care. One of the greatest dangers in today's opioid crisis is polysubstance use. Many overdoses involve opioids combined with benzodiazepines, alcohol, or stimulants. Combining opioids with other central nervous system depressants dramatically increases risk of respiratory depression and death. Even patients taking prescribed medications may be at risk if opioids are added. For NCLEX, if you see opioids plus benzodiazepines or alcohol in the stem, think high overdose risk. Prioritize monitoring and respiratory assessment. When answering NCLEX questions related to opioid use disorder, think in order of priority. First, assess airway, breathing, and circulation. Second, determine if the patient is intoxicated or in withdrawal. Third, evaluate suicide risk and co-occurring mental health conditions. Fourth, consider long-term stabilization with medication treatment. If respirations are compromised, intervene immediately. If a patient is stable but uncomfortable in withdrawal, provide symptom management and explore treatment options. Safety first, stabilization second, long-term recovery planning third. Opioid use disorder is a chronic medical condition, not a character flaw. As nurses, we save lives through rapid recognition of overdose, appropriate naloxone administration, compassionate withdrawal management, and education about medication treatment. Understanding the difference between intoxication and withdrawal, knowing when to act, and reducing stigma are core nursing competencies. In the next module, we will move into stimulant use disorders and other substances.